guess I have to do it. All right, we'll call the meeting to order.
Commissioners Fahey, Hearns,
Present.
Latanzi, Wiley,
Present.
Vice Chair Fluke,
Present.
Chairman Derryberry. We do not have a quorum.
Okay, do we have somebody to do the invocation? Anyone? Can
I can.
okay.
Let's bow our heads.
Stand it, don't we?
Dear Heavenly Father, we thank you this day. We thank you that you brought us together to do your business, Father God. We ask that you give us open hearts and minds to speak the truth to what we should do for this commission, Father God. We ask that your blessing be with us and guide us. In Jesus' name we pray. Amen.
Okay, if everybody could stand for the Pledge of Allegiance. Put your right hand over your heart. Ready, begin. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay, so do we just hold the minutes off? Okay. All right, so I'd like to invite our guests, our presenters tonight. So thank you so much for coming. I know it was a long way, and we've been trying to plan it for a while. So do you want to come up and introduce yourselves? And
So good evening. I'm Rachel Castaneda. This is Sherry Larkins.
Hi, I'm Sherry Larkins. Nice to meet you.
Nice to meet you. Thank you for coming.
Which is a little awkward. So we're really excited to come before you all and just have a conversation around prevention and best practices that we can share with you that you can consider as you're planning activities around prevention targeting 18 to 30. I was informed it was adolescent and young people, so I will kind of start there quickly and then kind of move towards the target population. So I'm going to probably do most of the talking, and then Sherry will add to this. Smile. You do have a packet in front of you. But just to save trees, I printed it, and I meant to print it in black and white. I mean, in color, but it came out in black and white because I chose the wrong printer. And so what you'll have, what I want you to focus on, is just the colored page, the first page right in front of you. They're not double-sided, your packets. So when I talk about substance use in general, I've been in the field for, well over 20 years with the UCLA Integrated Substance Abuse Programs. Sherry's also with UCLA Integrated Substance Abuse Programs, and I'm also with Azusa Pacific University. And within the last 2 decades, I've really honed in on the youth population, defined broadly using the Centers for Disease Control age definition of 12 to 24. And really this is really interesting, shifted the conversation around prevention with the older adults. So this is a real unique opportunity. I think that you can pave the way with some best practices. So I will speak into that. A lot of the work, though, within substance use, as I've been in the field for 2 decades or so, has been isolated, where substance use has been the topic that gets added on or gets, it's a second thought, and very isolated, and that's the way we've done programs. We've done treatment that way, where they're isolated specialty clinics. They've been outside of the realm of healthcare, outside of behavioral health, mental health, and they've really been just attached to like legal law enforcement and specialty treatment programs. So doing that has really isolated us away from conversations around integration and how we can think about and adapt and borrow practices like prevention from healthcare and mental health. So the first slide I present is really framing it around it being a public health issue and not necessarily calling it drug prevention or substance use prevention, but really shifting the dialogue to be a public health prevention effort or behavioral health prevention effort that spans healthcare, mental health, and community health. And so that I like to start there and kind of use that framework. And so the first slide in front of you really, I think, contextualizes it being a public health issue. If you look at top factors related to mortality, and you look from the 1900s and you compare it to fast forward 2017, the mortality that we track from an epidemiological point of view has really honed in on the 1900s. If you look at that list, they're fairly just acute kind of infectious disease control related issues in terms of public health problems. But if you fast forward, you see that that has shifted to include, we still have issues with infectious disease and communicable disease, but largely chronic health issues. These patterns of mortality have shifted from acute, where we can kind of eradicate it, take care of it quickly, come into something where we cannot get rid of it so quickly. They really have no cure, and if you look at them from heart disease to cancer to accidents to diabetes to cardiovascular issues, largely they have no cure, and they all can be fairly self-managed and prevented. If you look at the graph in terms of prevention, if you look at the causal attributes of these leading issues killing off people in the communities across the country at high rates, the 40% of them, sometimes cited 50%, are all linked to behavioral issues. If you look at the behavioral issues, which are in the box below the chart, top behaviors that always get cited as causal attributes of the leading causes of death across the country every year: underage drinking, excess drinking by populations, tobacco use, and other substances, right? Cannabis, heroin, amphetamines. And then other behaviors like unsafe driving, violence, firearms, suicide. And then you get into diet, sedentary lifestyle or lack of physical activity, poor sleep, risky sexual behaviors, and then healthcare behaviors largely, which are linked to routine checkups and not really adhering to going to the doctor once a year, getting screened, and getting immunized. These are all health behaviors. So substance use, tobacco, alcohol, and other substances have generally, from a public health perspective, been contextualized as health behaviors, just like all these others that can go bad, right? And not really, what we've done, though, is we've isolated them into, like, there's these health behaviors and then there's drugs. So I wanted to kind of frame it from them being important health behaviors that are really important to the public health issues linked to mortality every year. And if you look at the next slide, part of the issue, and you say you do prevention really well with the younger age group, which is great because that's where it starts. Substance use disorders are adolescent onset, and we really need to do prevention well and get in front of it before they're 18 and within the 30 age band. Addiction, like other chronic illnesses in that box, has an at-risk period. And the at-risk period hasn't been 18 to 30. It's been actually 12 to 17. And there's the transitional age youth have been included in this. But one of the biggest risk indicators of developing a substance use disorder is age of onset. Right? So a lot of research has been identified around the 12-year-olds, the 13-year-olds, and linking age of onset to that because, if you go to the next slide, because of the developing brain, right? The brain doesn't fully develop until the age of 24. And the substance use disorders are preventable, they're treatable, but they're brain conditions that interact with multiple biopsychosocial factors. There's not a one-size-fits-all model of like, this is the recipe for a substance use disorder. We know age of initiation is important, but there are several other multiple factors there in the little chart, psychological, social, biological, that all interact and create this recipe for the trajectory towards substance use disorder. And so if you're going to be thinking about prevention, it's important at any age to really understand what are the risks and what are the protective factors that you're going to want to target, and what has been shown to predict substance use disorders from a risk trajectory point of view versus a protective factor. Because yes, it's the brain, but what are these underlying factors that interact with growth? And so I'm going to cover that. You're going to want to, in the next couple slides, so that's going to be important for prevention. So if you do community-wide needs assessments, that would be a very important step to understand among your 18 to 30-year-old group, what are these risk factors, right? Because we do know in the literature there's key ones, but they might change over time with respect to psychological risk factors, social, and biological. You're going to want to identify what are the leading issues that your community, particularly the 18 to 30-year-olds, are presenting with those factors to then really lead messaging around prevention. So if you look at trends, though, one thing that's going to get in the way of that, one thing to consider as you're doing prevention materials, particularly for this age group, is you look at trends. What are you trying to prevent? What are the substances that are commonly used among the folks out here in Lancaster area, Palmdale? And if you look at the data, I'm just presenting data, the top substance that's used across LA County, and it's broken up by SPA here right in front of you, is cannabis. Alcohol is not on this list, but it is alcohol, tobacco, and cannabis. So really, this chart here breaks it up by SPA, and Antelope Valley actually has high rates of cannabis. If you look at the percent of use in 2011 compared to 2015, this was prior to the passing of Prop 64, which got implemented in our county as of January 1st of this year. So Prop 64, as you all know, it opens up access and availability to cannabis for recreational purposes for adults 21 and older. So what does that mean? We already have high rates. In 2011, it was about 7.8% of your population here in the Antelope Valley area were reporting use. That doubled in 2015 to 14.2%. We don't know what it's going to look like moving forward, but this is something from a prevention standpoint. You're going to want to have parallel efforts where you're monitoring trends in substance use, so then you can specifically strategically develop your messaging around that substance. Because this is the thing with prevention efforts in general. They've treated all substances as a one-size-fits-all, saying don't use drugs ever, just say no, right? But this message kind of just glosses over individuals as to like, well, that means the harder drugs that are illegal. That doesn't mean the drugs that are available, that I can buy, that I see in my community. So you're going to have to be strategic around your messaging and really target the substances in isolation and really break down the education related to each specific substance in isolation to really get more bang for your buck. So that's an important kind of takeaway around monitoring trends and getting in front of trends or working against trends as they occur in your community. So cannabis is on the rise, particularly with your teenagers. The graph on the right is 12th graders. They're soon going to become, your 18-year-olds. And rates are not 0%. So when you think about prevention, it's reconceptualizing what you mean by prevention, because they're already using. So what are you going to be preventing? You're going to be probably shifting towards a lot of the work Sherry's done, and you're going to want to use not really necessarily the word prevention, but you want to use risk reduction efforts. Risk reduction is a more important term to use because you are preventing that trajectory towards developing a substance use disorder, that risk trajectory. I told you that substance use disorders are adolescent onset. These are adolescents here on this graph, right? They're the 17, they're the high schoolers that are turning to be adults, and they already have substance use behaviors. If you look across the country at national trends in high school, 8th, 10th, and 12th grade, substance use is very common. the rates are not 0%, right? In 8th grade, it's about usually 15%. Then by 10th grade, it goes up to a third. 30% of high schoolers have used alcohol and drugs in their lifetime. And then by high school, 12th grade, it's above 50%. So when we think about prevention, do we mean having them never use alcohol or drugs, or do we mean reducing risk so it doesn't develop into a full-blown disorder? So that, as you kind of shift your agenda to prevention, I would really hone in on risk reduction types of efforts versus the just say no primary prevention model that is touted. The other thing to think about as you develop your risk reduction prevention models is you're going to want to tap into risk reduction, but what do you want to reduce? What do you want to tap into risk? The big thing that's happening is all about attitudes about risk. So if you think about cannabis, which is the most dominant substance in your community, does your 18 to 30-year-olds think cannabis is dangerous? This is called a risk attitude. Comparatively, does the state as a whole think it's risky? Does the county as a whole? Does the state as a whole? Does the country as a whole? We are in an era of moving policy that's aggressive, right? We have across the state, we only have 4 states. Across the country, we only have 4 states that are adhering to the federal law. Federal law is cannabis is illegal. It has not been approved for medicinal purposes. It has more harm than safety at this point to be determined, so we have ongoing research. However, across this country, we have about, most other states besides the 4 have medicinal marijuana programs. They have programs around low cannabinoid kind of cannabinoids for medicinal therapeutic properties. And then we have 10 states right now with recreational laws. California is one of them. So what does that do? What does these policies do to the public attitude around harm and safety, around availability or ease, accessibility? From a public health perspective, from risk reduction, prevention perspective, you need to, part of your needs assessment that I would encourage you to do is poll attitudes about risk around cannabis, around alcohol, because then that can drive your messaging around risk and safety. What do Lancaster residents think, or Palmdale, or this AV area, Antelope Valley, think about cannabis? And if you look at the data, this is pretty representative of young people. These are the 18 to 25-year-olds, and then 26 and older. The 18 to 25-year-olds you see there on the left-hand side, their perception of risk in terms of cannabis being highly threatening is very low. It's the lowest. What does that mean? They think it's a medicine, they think it's safe, and don't tell them not to use it, right? So your prevention messaging and risk reduction efforts really need to ramp up the types of education that you need to do to actually go against the myths that have been developed in our state around medical marijuana, right? And really shift to be able to tap into these risk attitudes. You're going to want to affect this area in particular. If you look at the graph on the right, this is the figure around perceived availability. This is how easy it is to get cannabis, and that's the top pink bar. And if you look at, this is 12 and older, this hits the general population, it's very easy to get, right? This is what easy access and low perceptions of risk equal a formula for continued use that then will land themselves into that trajectory towards substance use disorder, which is the next slide. If you look at the rates of treatment admissions in LA County, which covers the 8 spas, including the Antelope Valley, this is rates of treatment admissions. This is for youth. Last year admissions, a snapshot, the year before, I'm sorry, which is pretty representative of this last year. Cannabis was the primary substance where individuals were receiving treatment for. And so there's this perception that cannabis is safe, it's legal, it's not addictive. But if you look at our treatment programs, those that are in treatment have primary issues with cannabis or secondary issues with cannabis. And so this is a chart there, just to not to be taken lightly. The next slide, what I shared earlier was that age of initiation indicator. So it would be interesting from a prevention point of view, not interesting, but worth your while in your needs assessment or in your efforts around risk reduction, is to include in your education messaging this notion of risk and tie it to age of initiation. There is the chance, high probability, that of your 18 to 30-year-old crew, if you start asking them when they started to use alcohol and drugs, the proportion that's going to say, when I was a teenager, 12 to 13, they're the ones that are at most risk. So this could open up efforts for how you target your efforts around prevention. You're going to want to tailor prevention and target prevention to those that are maybe categorized subgroups of risks, because those that have been, those that are at most risk for developing a substance use disorder is starting use earlier. And if you look at the data, this is a heat map of individuals, of young people in LA County who are in treatment. If you look at this, it's a lot of busyness here, but the darker saturated red indicates that there's a greater number of youth who were age 16 to 17 at admission. They started or initiated their primary substance use at just experimental curiosity kind of types of attempts at 12 to 13. So there's been a trend, though, if you look at trauma and co-occurring related disorders, they tend to use earlier, 10, 11. So this is something to keep in mind as you tailor and target your risk reduction prevention messages around populations, and include this as a really important red flag to tailor messaging around risk. Then next slide, you're going to get into, okay, what about prevention? This is the continuum of care, and there's been not so much, there's not a lot of prevention best practices for the 18 to 30-year-old crew. So you are gonna break ground in this area. There's not a lot of effective strategies for the younger age crew as well. And so this has been a big issue for our field because of isolating substance use and the way substance use services have been funded. They've been funded largely by the Substance Abuse Mental Health Service Administration, SAMHSA, who has a carve-out, it was called the block grant, and they would give, from a federal level, states money to do either prevention or to do treatment, right? And what the pot for prevention, the money was all geared towards primary prevention, getting kids to never use alcohol and drugs, right? The pot for treatment was given to those whoever used would get mandated or sent to treatment. There was a dichotomous model we've had in our field. We've never had in between these at-risk kind of intervention programs of where I feel like is a high recommendation where you can shift prevention efforts. If you do have funds to carve that out, that would be definitely an area of an area that would work. So what kind of prevention, what does that look like? So next slide. In order to reshift your efforts around prevention for 18 to 30-year-olds, you're going to want to contextualize it around what I started off saying, health behavior. Why? There's so much stigma and shame. There's so much embarrassment. There's so much negativity linked to substance use in our communities throughout our country, right? We still have a war on drugs. We still have a lot of penalties and criminalization policies that are associated with drugs and alcohol. And so to shift and open up opportunity to interact and engage community members, you're gonna want to frame it as a wellness initiative, as a public health initiative. You're not gonna wanna call it drug prevention, alcohol prevention, because then there's this isolation again and shame, stigma, embarrassment. You're gonna have issues with self-reporting, right? So you're going to want to frame it around risk reduction, health promotion. You're going to want to align your policy regulations around that and reshift if you are. So we do drug prevention. You're going to want to maybe change some messaging and some framing. And so I cannot emphasize that enough. And so if you change slides, if you look at pathways towards substance use trajectories, these are risk and protective. The one arrow that's pointing down at integration is important. This is, again, you're going to want to integrate your prevention or your wellness or your risk reduction at multiple levels in the community. What do I mean by that? Well, if you look at the next slide, prevention today looks like the figure on the left-hand side, where prevention is treated like vaccination programs or immunization programs. You get it once and you're done. You've got exposed to prevention. Our work is done. And we have failed royally as a country doing prevention that way. And we continue to do it, right? And it's really targeted at schools and law enforcement. And it doesn't target 18 to 30-year-olds. It doesn't target different sectors of the community, right? And so it's this isolated globbity bloop of you're one and done, right? And that's been unfortunate. And it's hurt our communities and it's hurt our field. And so the effective prevention is the figure on the right, where it's continuous, it starts early, and it's given every year throughout the age span, throughout, right? So from adolescents to young adults to adults and older adults, and elderly. Older adults, elderly, I don't know what the term's used, but you know what I mean. And it's gonna span all sectors of a community, particularly local policies that are gonna then align with healthcare and behavioral health. And by healthcare, that's a large term for mental health, for areas of dentistry, for areas of community clinics, for public health, social welfare kind of entities, right? So healthcare is defined broadly. I just don't mean hospitals there. And then various centers, and then schools, and even local businesses. And so if you turn the slide, this is really the message there. Need to put attention and effort into rethinking and redoing the system so that it's responsive to youth. So that means when you do message about alcohol and drugs, you are not only messaging about alcohol and drugs, you are messaging it within a wellness. So you're talking about sleep and good sleep behaviors. You're talking about diet, good diet behaviors. You're talking about physical activity, good tech health, and tobacco, alcohol, and cannabis. You are not isolating the talk to just be, don't drink. That doesn't work. But if you include it as an overall wellness initiative with, let's talk about your sleep, let's talk about your tech health, let's talk about your diet, let's talk about your alcohol and drug use, that people are listening, people aren't embarrassed, there's no shame, there's no stigma, and it's a health behavior that can go bad. Just like diet, just like physical activity, right? So this is really a best practice around prevention, risk reduction. You're looking at all of these behaviors that are risky and can lead to trajectories around chronic disease and disorder. Okay, so that is a big point. And then the focus around prevention should be risk reduction. That's the next slide. So you're gonna want to not blanket one-size-fit-all prevention. This has also been a problem with our prevention efforts. We treat everyone the same, right? Homogeneous. We are so different, Everybody's substance use is so different, right? There's so many varying reasons. These are the risk and protective factors. I'm linking this back in. So the best practice that has been kind of moving into our continuum of care around behavioral health and substance use has been you identify their risk and you triage that risk. You do not treat everybody as the same. So we're moving away from holistic messaging to very personal-centered messaging, individualized care, right? We're seeing this whole movement in healthcare towards patient-centeredness, individual-centered. The same thing has to happen with prevention, right, when we get to risk reduction. And so the model, and Sherry's done a lot of this work with Coalition. She has a grant that she's wrapping up from the Anti-Drug Coalitions of America. It's called CADCA, and they're in Virginia. And they fund all of the prevention coalitions across the country in the various states. And she's really changing her work through UCLA with these coalitions, have been changing them away from primary prevention to doing this one-size-fit-all messaging to risk reduction. And you're going to want to universally implement procedures here around screening in justice settings, in healthcare settings, in business settings, employment settings, so wellness work programs. Do they have an identified tool, that's number one, that can identify risk? And so there's these tools. The next page shows you a very short, brief, 6-item tool. It's called the Screening to Brief Intervention. It's been validated as an objective tool to use to identify risk. It's at the National NIDA, the National Institute on Drug Abuse, has it on their website, where this tool can be implemented across your community, right, across your county, and around this whole notion of becoming a community prepared, having community preparedness. So this is a term that Tom McClellan, he was the deputy drug czar a couple of years back. He took research and science to the White House. He was with the University of Pennsylvania, and he was the director over the Treatment Research Institute, TRI. And what he said was, in order for communities to do drug prevention, they should move away from the term drug and do just broader prevention within this kind of health umbrella. But they also need to think about community preparedness, just like emergency preparedness. Think about disasters and reliefs. Every household, every business, every school, every setting has this first aid kit or has this kit around disaster preparedness. The same idea, he said, should be shifted to develop community preparedness around substance use. And he says one small step to do that, which is the low-hanging fruit, is does your community have one thing in common? Are they all identifying risk the same way? Is it the same kind of protocols? So this is the idea, where it's a universal screening tool that shouldn't just be implemented in one place to identify risk. It should be used comprehensively in various settings, so you're all talking the same language around risk. And so this is a model that can be adopted under number one, where it's implementing community-wide screening. So you're monitoring and you're identifying risk as a community using an evidence-based tool. So that's the tool there. And then number 2 and 3 kind of go together. You're going to want to put money and resources into workforce development in these settings, right? If you are going to target businesses and you're going to target law enforcement, you're going to target schools where adults go, you're going to mental health arenas, community clinics, you're going to want to train them and educate them around this wellness initiative, curriculum, and around this community preparedness, how to implement the screening tool. And should risk be identified, should use come up, what do they do? Do they just kind of file it? Do they refer? And I think we're quick to say, refer them somewhere. And where's that referral? It's a treatment program. Why do we think they need treatment? They don't need treatment more times than not. They need a conversation about what? Their risk that was identified on the tool. Potentially through that conversation, which is 5 to 10 minutes. It's called a brief intervention. They might identify them to need some type of specialty care, and then they would be able to link or make a referral. However, just identifying that this person is using substance use and jumping to treatment has been something we've done and we've hurt ourselves. We need to treat it like a public health issue, just like diet, just like sleep, and say, okay, well, let's have a conversation about you're lacking sleep, or you're not eating well, or you're not exercising, or you're using alcohol and drugs at a risky level. Let's have a conversation first. And so training can be done in these various settings about a brief intervention, which is the next slide around components of early intervention. This studies have shown, and it's the article there, brief alcohol interventions for adolescents and young adults. This is based on systematic reviews and meta-analyses. Brief interventions, early interventions work. It's this in-between between prevention and primary prevention and treatment. It's this in-between space that we have that we can have a conversation using motivational interviewing, using like, what's going on? Let's talk about your risk. And that is opportunity for us to really shift the norms about, oh, you're using drugs, you have a problem. Go into that treatment center. That's hurt our field in a big way versus, oh, you're using alcohol and drugs. Seems like you might be at risk. There's a risk there, just like you're not sleeping well, just like you're not eating well. You're just at risk. Let's talk about your risk. And shifting that to risk reduction is very important. So here's these training can happen. And so people like Sherry train, so she's blue in the face on early interventions, and she's been doing that work with the coalitions. And so that can be something that could be part of your prevention kind of landscape. There's other opportunities. I know Tarzana's in the room here. They probably can partner with different organizations who can give you the resources around how to do brief interventions. And so you do have resources in your community around brief interventions, so I would tap into those and develop an advisory group like the ones in the room. The other thing, and they're also in the room, you're going to want to include environmental efforts largely, right? What does that mean? So that's number 4, ongoing public health campaigns. This is important. And this is what I mentioned earlier, where you single out a substance. Maybe it's cannabis, and you kind of roll out a campaign around cannabis. Or then you target alcohol and you roll out a campaign about alcohol. However, when you roll it out, you're going to want to contextualize it from a wellness perspective, not from like, it's bad, you're bad, not from shame, right? So it would be important to continue to do that, because you are up against, as a community, and we're all up against this, advertisements and business shops that are going to be put on streets where it's going to be everywhere and it's going to be saturated. So environmental campaigns that are ongoing, multi-pronged through ads, through bus stops, through just community events are so important. They're critical. You cannot do effective prevention without them. So I wanted to mention that. And you can work with your partners who are able to do that in the community, like Tarzana, like other folks who have prevention money and resources around environmental campaigns and how to work with your partners. The next slide I cannot emphasize enough, and I'm almost finished here, even though it looks like I have a lot more. A couple of other things around prevention with young people, young adults, is integrating technology. So we're in an era where Facebook, social media, InstaChat, Instagram, FaceChat, all these things are happening. And so in order for us to effectively engage and put out things like campaigns or messaging or resources, you're going to want to have technology aids across settings. And so as you partner with your justice system and your school system and your businesses, you're going to want to tap into what they do to advertise and create some space there where you're going to want to integrate your risk reduction or your messaging, or put resources into, like, for example, the first one is screening. There's growing use of technology for screening. So for that screening universal tool, you can advertise it within your partners as it being captured from like some way through technology, through some interface that they might use, or through some other ways they track and monitor trends. So that might be something to do. You might also want to do, like the third bullet down, this is for service provisions. So remember I mentioned the brief intervention. So what we're seeing more and more is the use of virtual avatars or virtual peers or virtual things. And so there's resources that are put out by the technology. So Sherry, what's that group, the ATTC, the one that worked with the group in the social work group where they developed that avatar? NORC.
Oh, yes.
Yeah, so they have already designed brief intervention that can be, I don't know if it's coordinated or purchased or whatever that is, or used because it's funded under the federal entity. But how can you incorporate technology-based interventions if there's a lack of resources, that you can say, look, we already have a model that you can use. You don't even have to do it. So I would look into these kinds of things of incorporating technology. So that's the next slide shows something that's being done with a hub and spoke project across the state that's really addressing opioid issues and really trying to expand the use of medication-assisted treatment, things like buprenorphine, Suboxone, Vivitrol, for issues of opioid use disorder that are hitting different parts of the state in different ways. And so part of your prevention, again, might be expanding access to medication-assisted treatment, or messaging around the importance of medication-assisted treatment. I know Tarzana Treatment Center is a hub, or a spoke of the hub. I forget what you guys are.
They're a hub.
They're a hub. And so what they're using in that program is they're using like virtual technology. It's Bright Heart Health. This is in California. And this is, again, if you're limited in resources, this might be something where, or there's shame and stigma where they don't want to go to a treatment center, or they don't want to say that they need that. This could be something that you kind of promote, and they can interact with it online. Sessions are private. It's by doctors and psychiatrists, social workers. So this is something that can be thought about as well. So that's an example of technology there. I'm not going to get into much coordinating care. There is, if you do develop a resource list for the Antelope Valley, I don't know if there's something centralized, because we do know with substance use, sometimes you can come the back end of prevention. We know substance use issues are linked to housing need, mental health issues, school issues, financial, employment issues. And so if you work and create a resource tool list, like to mental health services, to workforce development services, and then also include substance use, again, from a holistic perspective, not just here's substance use resource, but you're going to want to crouch it under a larger resource inventory. I would recommend that from a wellness prevention standpoint. The last thing, this talks about the evidence-based programs that have worked. They have the different age groups, 0 to 10 there, ages 10 to 18. These are all effective prevention programs that have been shown to be effective in junior high, middle school, and high school settings. You do say you do prevention really well at that age, so I'll kind of ignore that. But what I recommend is on the right-hand side. This is what I talked about earlier. You're going to want to have a prevention curriculum that introduces it as wellness. And you can then get into smoking, you can get into substance use, then nutrition, safety, sexual health or healthy relationships, mental health, right, life. So you're going to want to, and so this is a curriculum we've been working on that we can kind of share with you, and if you want more information or training around that, but this is how I would focus prevention efforts around. So I just wanted to give you an example around that. And then other alternative health promotion interventions, if you can attach prevention work, right, or get them to a community place, you're going to want to incentivize it. You're not just going to say, we're going to talk about drug prevention here or prevention. You're going to want to do wellness activities, things like martial arts or arts therapy in a community setting, and then you can integrate health education around that. So they're going to something like mindfulness or like a yoga program, but then they're getting education around alcohol and tobacco and cannabis, right? So again, think health promotion broadly. And so that's just ways to do it. You can do it through job training. We're going to have job training and building resumes, but really you're going to also have some drug prevention, right? So this is that slide that kind of talks about that. Or GED prep and tours and talking about college, and then you integrate some substance use prevention. So these are just examples where your community-wide effort is on job opportunities, but then you integrate some prevention work there. And you can work with your partners in the community like Tarzana and others to do that. I'm sure they'd be happy to work with you. The last thing I want to allude to is family. You're going to want to do family, if you can market the prevention as well and target it being a family affair versus an isolated thing, and you're just targeting individuals. That's also a best practice model where you're going to want to include the whole family, because what we see over time, and this has just kind of hurt our field and hurt the recovery of individuals, is they usually get in trouble and they get mandated to services by themselves. It's not like you and your family need to go get services. It's you need to go get services and get your ticket punched because you got in trouble or whatever, and the family gets to stay home, and maybe they can participate, but they're not referred together, and so it's a choice thing, and they're not educated, and they think it's not a health issue, it's more of a moral issue, and they just need to stop right now. So if you can educate families, right, and make it a family affair, and one way to do that is by providing parenting groups, right? Working with WIC partners, working with different entities that work with families, breastfeeding, right? In your community, you can then build prevention in that way, where you target family, maternal and child health programs, or if you can offer parenting classes and have substance use be part of that, that's really cool. So here's some examples: parenting classes, community-based organizations at parks, outings, at the library, working with the YMCA, maybe businesses, encouraging some stuff there and getting family participation. Here's some resources on parenting practices and some tools that are free. Positive Parenting Program, Triple P, is very useful, evidence-based program that Department of Mental Health uses, but the Partnership for Drug-Free America and the resources on the bottom there, it has free resources for effective parenting. And so and with substance use, that can be like a low-hanging fruit. And the last thing is on resources that you should tap into that are happening from Department of Public Health. One's on cannabis. And so this is a free website that, I don't know how familiar you are, but you're going to want to also look to see what's been out there so you're not reinventing the wheel. You're going to want to utilize and incorporate existing resources. So who's doing, like you talked about Penny Lane or Tarzana or other entities, what are they doing? Because they're actually doing stuff that's probably really impactful. So how can you build upon that, not start and duplicate efforts? And so I wanted to mention this because there's a lot being done right now around cannabis. So how can you capitalize on some of these resources? There's stuff for families. There's other stuff around integration work that might be good for you to include. So I'll stop there. So I know I talked a lot. We have our emails here. Sharon, why don't you come up? If you guys have any questions and we can dialogue around some stuff. I said a lot of stuff, but I hope some of it was useful.
I just want to say thank you very much. I thought it was very useful. We do a lot of work with the maternal child health in my organization, so we do a lot of that work on the front end prevention. Yes. I really like the risk reduction instead of using the prevention piece, because I think that is more impactful, and that's where we're kind of, it really validated what we're thinking of doing in this community and
Wonderful.
how we want to address it. I wish there was more happening at the college level, which were, so we weren't pioneers so much, because it's great being pioneers, but it's also nice having other resources too and seeing what's been done and effective. But we really were looking at the more wellness and looking from that, the coping skills and things like that. So I really appreciate it. It really helped.
It was
and-
affirming. Yeah, great.
Yeah, it was very.
You guys
affirming.
are like doing it. Just needed some, if you need some resources, our emails are there.
Great.
We're happy to share, anything that you follow up, say, can you send me more information around this program or this model? We're happy to do so.
So I did have a few questions. I have a few questions, and maybe some of the other commissioners do. One of my questions, has there been a comparison, because I think it would be really powerful and impactful, especially around just the risk reduction piece of it, of like doing a comparison around, I think our society is very quick fix, and I think that's why coping with stressful situations or things like that, we tend to go to the easier thing that's going to make us feel good and relaxed, quickly. But we know that doing that can also have long, you wake up later, you wake up more tired, you're less productive, after a night of having fun or something. I wonder if there's ever been any comparison between like going to a yoga class and the impact of that or taking a walk and the impact of that over, having a drink or something.
Yeah,
and
no.
what that comparison,
Yeah.
because I think people,
It's a good
taking an hour
question.
walk has like a 3 times more effect as opposed to having 3
Yeah.
drinks in an hour or something,
Yeah, you bring up a good point, and I'll say something and then let Sherry add some comments and some thoughts. Something to keep in mind with prevention efforts that you made me think about is having choices and having options. And so one thing that as you start to think about like the yoga and the martial arts and the maybe like festival of some sort, really know what your 18 to 30-year-olds like to do, maybe whatever event it might be that to get them there. There has been work in the area of like recreational programs like exercise. There's a study that we finished at UCLA on the efficacy and effectiveness of exercise compared to just drug treatment as usual. And it did show to be significantly more effective at shifting them away from wanting to use because things like wellness and exercise and diet and nutrition all affect the same parts of the brain. And also provide them with different outlets and mechanisms around biopsychosocial factors that, like you said, they might be self-medicating. And so one area, though, that we've been really kind of shifting towards is these like stress management kinds of activities. So that might be, you made me think of that there's these like mindfulness or yoga, but sometimes communities they can't do that and they're limited. So maybe think more broadly around stress management kind of activities. So that made me think of that. But the studies, there are studies like the exercise one, but unfortunately there's not many that have been available because of the way we've done prevention versus treatment. And really we're shifting. There is work around, if you look just like at tobacco and some studies that have looked at alternatives, we can learn a lot from that. And there have been, what we can learn about is policy works, right? Ordinances, you can't smoke in bars, you can't smoke in public places, you can't smoke, right? So like campaigns, public health campaigns and policy works, but we also have done work around giving them other alternatives because you see tobacco cessation in healthcare, right? Integration in community health clinics. So that integration work is really important as alternatives, and what they tell them in those places is exercise and diet and sleep. So from that research, yes, those just looking at tobacco.
Right.
But for larger alcohol and other drugs, we don't have a lot of evidence because that hasn't been done. But for tobacco, it has.
Okay. Great.
Do you have anything?
No, my only addition is, as Rachel pointed out, that most of the work that we have is already in populations who are in treatment. So
Yeah.
they're already clinically diagnosed, and that the benefits of exercise, wellness, are strong mostly through mediating mood. So for people who have co-occurring disorders and who particularly have mood disorders, the influence or the benefits of exercise are stronger among those populations. And so it looks like when we manage mood better, we can improve craving and use of other things because we're improving mood. So, but mostly all the stuff that Rachel commented, the stuff I know about, which is already exercise and wellness and mindfulness often helps patients who are already clinically diagnosed. It's one of the reasons why you see Matrix and other types of treatment programs incorporating some of these now into, some of these almost like adjunct into their treatment settings. And there's increasing research funding around it because we weren't traditionally looking at things like that. We kind of thought of them as they're going to be helpful, but is there evidence behind them? And NIDA began funding these about 10 or 15 years ago, and we really do see lots of benefit. So,
The other thing that we see to add to that is giving alternatives to behavior, right? So managing mood and managing mental health, but also giving them something else to do. So things like the more you can implement stuff around life skill stuff like jobs and volunteering and having these opportunities in the community more and more, those are the protective factors you're going to want to have versus.
I think our community right now is getting together and moving towards the whole workforce training in the neighborhoods that have lower social economic status, is to have training in those neighborhoods for jobs, how to get a job, how to keep a job, because that seems to be a gap in this community in terms of overall health, is that they need the skills to get it, they need the skills to keep the job.
That's right.
And then keep going, and we are gearing up towards that now, which is really important component that we haven't been doing.
Around risk reduction. So that can be a perfect risk reduction where you're honing in on those skills in those areas that are linked to substance use, continued use because of unemployment. So you're coming from a public health back-end perspective, and that's exactly the model.
Right, and I see out here too is there's a lot of youth that are extremely physically active in a lot of activities and very successful at it, but then when they leave high school or they leave college, they're not in those physical activities, in those sports, they're not getting the reinforcement, the positive, and that's what defined who they were. And so now they start failing because they didn't get other skills, and that's something that I see here because we have a lot of people who are extremely successful at all different kind of sports, male and female.
Yes. So.
But then there's life after high school and there's life after college.
That's right. So you mentioned college, you mentioned schools and community colleges, vocational programs, and four-year colleges right across the board here. This is an opportunity to, low-hanging fruit, meet with the counseling center at the universities, at the community colleges, and talk about how are they identifying substance use risk, alcohol, drug, They all have these community health assessments that they do that track, that they have to report to from the National College. They're accredited. They have to do like mental health needs, suicide, right? So they track these key indicators, and alcohol, tobacco, I feel like are these two pronounced ones. And so you can introduce that universal screening tool and ask them, well, what do you do with that when they say yes to alcohol and tobacco? Chances are they're going to say nothing, right? So that's an opportunity to offer training around brief interventions, so SAMHSA has funded a lot of these initiatives in colleges. So there's those models, web-based trainings that are available specifically for colleges. So we can provide you with those links.
That would be great.
To that. So that's actually that's low-hanging fruit for you guys that you can really capitalize on.
yeah, it's almost like for college counseling centers, doing brief interventions and early intervention should probably be the number one
Yeah.
thing they do, because they're with the riskiest population. College students are most likely to binge drink. And so it is a
Vape
target
right now.
population that they could be working with. And I don't know if
Vaping's really huge right now.
vaping
Hookahs.
around. I'm wondering if they have also a drug and alcohol counseling program. I'm not sure, but it's potentially an opportunity for folks that are even going to school as well, because other universities and colleges do the same thing, where it offers a clinical site, a training site actually for people who
Yeah.
are doing work as well. So it has twofold, which is developing a workforce that is skilled and knowledgeable to be able to sort of enter the work market around, when they leave, around issues of health and wellness and substance use. And at the same time, providing a service for students themselves, which is the highest
Yeah.
rate of binge drinkers. So they really could be screening and making referrals right to their own system.
We did a program at UCLA in the ASH Center, the health center. So they implemented, students come in and they use a tablet and they do like the questions they have to. And then the screening tool for the one I showed you is part of that. And should they flag risk, they were all trained on how to do a brief intervention.
That's wonderful. Yeah, and our local school is starting a certificate program around that, so.
Yeah, so
Great.
that's great. So I'm glad you
Yeah,
mentioned
that's actually
that.
a good opportunity.
So I only have two other really quick, they're probably really super quick questions, and I apologize for keeping everybody. Or one really. The Bright Heart Health, that's great, it's for people experiencing substance abuse?
Yes.
But is there a component to it for the family members that have loved ones?
Yeah,
that-
so this is a video conferencing, and this is something that is expanding for offering family members as well. So they have different components.
Okay.
So they're I can send you the link to that. So the sessions are conducted at weekends, evenings. They can use their phone, tablet, computer, and they also have resources where they're hooking up with, like, for parent groups and multi-family educational groups as well.
Okay, great. And I don't know if you guys have done this, but I've been thinking about it a lot. Has there been any correlation between, like, ADD medication that is correlating now with substance abuse disorder? Has there been any, like, matching of, because I know, like, I have kids that are older now, but when they were younger, it started the wave of, everybody getting on Ritalin and Adderall and things like that in elementary school. So I'm just so curious on how that's affecting now our 18 to 30-year-olds that are having substance abuse.
There are data on this. It may be a little inverse in what you're thinking, because we've worked with a lot of methamphetamine users, and methamphetamine users in particular will often say there's a connection between
ADHD.
between me taking medications when I'm younger, and I get that same sort of inverse benefit from taking a stimulant now, where it actually kind of calms me down and helps me focus, as opposed to what many people experience when they take speed, which is the opposite. What the data actually show is that if a youth is properly diagnosed with ADHD, that actually being untreated as a youth places them
More
at
at
higher
risk.
risk. So being untreated actually places them at higher risk than being properly managed with good care that may include medications. So untreated is riskier.
And behavioral based.
And behavioral based, yes. So
Not
being
just medication.
Being not in care is worse.
Okay, great.
Yeah, I would say during the sixties, the seventies, they did not treat a lot of medication.
Yeah.
It was all new, and kids were getting it.
This is a problem. Yeah.
And so there were no other counseling or anything, it was just come get the pills, get your kid calmed down so they can sit and behave in class.
And then they don't eat.
And those are just
You know,
people coming in with big
Well, and now we have this whole influx of technology and gaming and how that
taking PE out of schools.
interacts with, these areas of the
A
brain.
lot.
Right.
We have a lot.
After we just told you how great exercise is for mental health and for reducing risk-related
Yes.
substance, and we keep taking PE out of You know,
Yeah.
we keep taking exercise away when they're at young ages, and
Yeah.
it's just counterproducctive. Yeah.
Yes.
Do you do any of the other?
Yes. I guess the 10 to 12-year-old, I mean, to me, that's kind of strange. But to me, I look at the advertisement, and like when I was a kid, did nobody tell me not to drink? You know, they said you can drink when you get 21, which, okay. Now, when I was in the 6th grade, I saw a movie about smoking cigarettes, and they actually showed the guy having taking his lung out, and I passed out, so I didn't want to smoke. Never smoked.
Yeah.
I did drink early, don't drink anymore, but it's kind of odd, you know, you see, I'm watching TV and I see Miller Lite, and it's a really nice thing, and so if I'm a 10-year-old, guess what I want to drink? And so maybe we should have, I don't know, not you guys, but maybe some kind of advertisement to say, if you drink, it's going to hurt your liver and it'll kill you. I mean, really drastic, like, I mean, the same with cigarettes, but because if not, then, you know, I mean, a 10 to 12-year-old, unless you're over in Europe, like in Germany, you can go buy liquor for your parents, and there's no age limit, but where does he go out and buy liquor? You know, and then go on. So, I don't know, it's just kind of an oxymoron for me when I think that I want to stop you at the early age. I don't want to stop you at 38. I want to stop you at 8. I want to stop you at 10.
That's right.
So that you really don't want to drink. Like I said, I was convicted. I'm not smoking those cigarettes. And, you know, because taking that lung out was very hurtful. I mean, I passed out, like I said. So is there something like that going on?
You know, you bring up a very important issue with the way we do prevention and our messaging, right? And we don't get it right a lot more times than not. You bring up scare tactics, what kind of messages work. Some say too much fear, that they laugh at it, you know, but from a public health perspective, and this is that slide where it's effective prevention, and it starts at 10 and then it continues, where we're actually continuously showing them these messages. Because if you think about advertisements for alcohol, good example, we're saturated with them. We become desensitized to it. It becomes something that's normal. We're going to see the same thing happen with cannabis. Tobacco shifted that, and they went away with it. So that's where you see good policy. But we have to really learn from that model around constant, continuous messaging, anti-public health messaging, and this is the importance of ongoing campaigns. You cannot do good prevention work without environmental kind of messaging and developing things that, right, make sense, and not just like we put out a campaign and we're done at age 10. That's actually not effective. You wasted a lot of resources doing that.
And you think all of the money that's going into advertising for use alcohol, use marijuana, it's like you have to be really savvy because you're fighting big, big companies in terms of opposing messages.
And what kind of messages work? Two kind of areas: scientific-based, non-judgmental, and peer-based models when you work with youth. So you're going to want the scare tactic with tobacco is important in the kidney. You're going to want to make a blend of them, right? There's some health danger, but then there's some peers that are saying it's really not cool to fit into this, right? Some peer-based kind of models. And you're also going to want to have some scientific kind of models around addiction and around these kind. So you're going to want to have messages that blend in information and really focus on risk, not you're going to die, but you're at risk.
Yeah, no, I mean, I understand.
And get them to think,
Yeah.
but at all levels continuously. And I think the other thing is you're going to want to, for schools, you're going to want to educate parents, because parents don't talk about it in the home because they think schools talk about it. But guess what? Schools talk about it every week by giving them a red ribbon once a year, maybe.
Yeah.
What do they do?
Yeah,
Nothing.
nothing.
So again, it comes back to the slide around what's prevention look like today versus what is effective prevention. When you think younger than 18, we're not doing it right. I don't know what Lancaster's doing, but this is a big issue.
Okay.
Still, my favorite advertisement for anti-tobacco and marijuana is the advertisement where the boys are smoking and their joint goes limp because it's associated with erectile dysfunction, or,
Yeah.
you know, and it really sort of took the masculinity out of smoking. So sometimes our advertisements are creative and effective, but often we're against, you know, messaging that's targeting youth and is so much bigger and more expensive than our tiny public health campaigns.
No, I mean, there's another one, I think it was like about acid this year, your brain on drugs.
Your
and-
brain,
The inhalants,
drugs, the
I mean, and so, I mean, I looked at that and I said, you know, it made sense. You know, I mean, and I'm not saying, I mean, like, the movie I saw was back in 1962 when I was 12.
Yeah.
So I know we're not there now, but at the same time, I think we need something there so that if it frightens that little kid a little bit, similar to me, then if we can save one, then guess what? Let's go get the 101 is what I'm looking at, because if not, then they're going to think it's cool to do. I mean, I look at the Bud Light commercial, and I think it's water. I mean, you know, it's not, it's going to damage me later, but you drink enough of it, then you got liver damage, and you got all these other things. So
Yeah.
I see that blend of
I do too. So I would recommend, you know, I don't know if this is done, but I've seen like communities become prepared that you work with your entities who do prevention, have funding. So I'm just going to use an example because Tarzana's here. You like Penny Lane or Tarzana or your hubs that get prevention dollars. I would, as a commission, I would recommend that they develop MOUs with the schools, with the law enforcement. You use your resources where they then do prevention at all levels every year, not just go in and do prevention
yeah.
when they need it or lack of resources. So it's this continuous integration work that is so key. You can't just leave it isolated. You got to push efforts to integrate them and blend them of how they make sense for your community.
Okay, thank you.
Yeah.
Thank you.
Thank you, everyone.
Thank you.
Thank you. Do we leave? Or how does this work?
You can leave if you want. Thank you so much for
We don't
coming all
have to
this
stay
way.
for the rest of your business.
Okay.
Thank you very much.
We don't have much more. So we don't have any public business from the floor as agendized items. We're putting the minutes next on the next agenda. Do we have? Oh, okay. So does David Paul, do you want to make a comment? Yeah, I would, yeah. Okay.
Commissioners, Vice Chair, Commissioners, good afternoon, and guests, thank you so much. You know, a lot of what I'll say, you've heard me say before, but it kind of a warm-up. And when we're talking about risk, just a joke came to me. The joke is, two guys walk into a bar. That's where the risk comes. They need to go somewhere to do something to mood alter, and that's why I talk about John Bradshaw and human recovery, and he said that addiction is a pathological relationship to a mood-altering event or substance that has life-threatening consequences. So we have a lot of pathological relationship to things that aren't drugs, just crazy ways to think. And our world is getting crazier. That's why it took me a whole year to come up with an acronym, WUDD, World Unraveling Dissociative Disorder. That gets laid on all the rest that's going on because our world is changing in ways that no one ever thought. Now, when you talk about the young people in treatment, a lot of that has to do for marijuana that they were caught and put into the programs. So my background is this. I began as a behavioral worker, and a friend of mine died, King Kong Bundy. He just died. And I put up a picture on my Facebook of him at a lounge I used to work in. And then all these things come flooding back because you don't think of these things. But this was almost probably 40 years ago. But what I did by day was I went to a treatment center for sexually abused children and used the family teacher model, a token economy, to change their behavior and change their lives and let them feel good. And then at night I went into the bars and I counseled young men who didn't know how to party correctly with some firm guidance. So between the mix of all these things, I realized, and I just want to tell you guys, one time in one of these meetings, I was very proud that they someone presented the statistics of children under 19, and 99% of them had tried drugs. I have two sons, 16 and 18. They have never tried drugs. That's because they have a father, and I'm a martial arts instructor. They learn martial arts. They have their own lives. And the point is to have people around you and goals and ambition and someone to help you. And that's all I have to say. Thank you for this community meeting.
Thank you. Okay, I guess there's no other business, so we will adjourn at 6:19-ish.